we start this lecture, could you please state your position? Okay. So while we await the poll results, let us start off with today's talk. The healthy ocular surface comprises of a functional unit that includes the tear film, cornea, conjunctival epithelium, meibomium, and lacrimal glands, and the eyelids. A normal functioning tear film is required to maintain the clarity of vision and ocular health. The tear film serves to provide ocular surface comfort, mechanical, environmental, and immune protection, maintain epithelial cellular health, and provide a smooth and powerful refracting surface for clear vision. There are several growth factors which are responsible for the wound healing, epithelial healing, mucin degradation, cell proliferation, profibrotic, and mitotic effects. So what are the layers of the tear film from surface downwards? Okay, so let's have the poll. Okay, so there are two concepts. One, that earlier there was the three-layer model, which was the air lipid interface, the aqueous, which consisted of 90% of the tear film, and the mucus layer. The newer concept consists of a decreasing mucin aqueous gel, which gradually decreases in concentration until one reaches the superficial lipid layer. So there is a heterogeneous mixture of lipids which are secreted by the meibomian glands. The lipids lower the surface tension and enable uniform spread of the tear film and provides the optically smooth refractive surface. The mucin component of the glycocalyx gel consists of an organized heterogeneous group of glycoproteins that promote a firm attachment of the matrix to the corneal epithelium, provide a viscosity and a low surface tension that aids uniform rewetting of the hydrophobic ocular surface. So, central to this mechanism is the elevated tear osmolarity. The tear film dysfunction leads to increased osmolarity due to elevated sodium concentration, and this is central to the mechanism of ocular surface damage. In a meta-analysis, Tomlinson and colleagues found a cutoff value of 316 milliosmolars per liters, which appears to provide acceptable sensitivity and specificity for the diagnosis of keratoconjunctivitis sicca. The sensitivity was found to be 59% and specificity 94%. The definition of the dry eyes has undergone several modifications. The latest is what we follow now. There are several components to this, which includes that it is a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, tear film instability, and potential damage to the ocular surface. It is accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. So dry eye can be classified into aqueous deficient and evaporative dry eye. Aqueous deficient dry eye may be Sjogren's or non-Sjogren's. Sjogren's can be primary when it is not associated with any other autoimmune disorder. However, the other disorders that can be associated with Sjogren's include the mixed connective tissue disorders, Wegener's, primary biliary cirrhosis. I'm sorry. So there are several. I'm sorry, just a minute. Yeah, and there are several non-Sjogren dry eye syndromes, which includes lacrimal gland deficiency, lacrimal gland duct obstruction, reflex block, and systemic drugs. The other category of dry eyes include evaporative dry eye, which include intrinsic and extrinsic mechanisms, and we shall be discussing all of these subsequently. So Sjogren's is a very common and important cause of dry eyes. So can we take this audience poll of what is true of Sjogren's except? Okay, so there are a set of criteria which help classify Sjogren's. These are the revised international criteria for ocular manifestation of Sjogren syndrome. They include categories such as the ocular symptoms, that a positive response to at least one of the questions, such as daily persistent troublesome dry eye for more than 3 months, recurrent sensation of sand or gravel in the eyes, need to use tear substitutes more than 3 times a day. Oral symptoms such as daily feeling of dry mouth for more than 3 months, recurrent or persistently swollen salivary glands, frequent need to have fluids to aid swallowing of dry food. Ocular signs include positive Schirmer's and Rose Bengal scores, histopathology of the minor salivary glands show a number of lymphocytic foci. Salivary gland involvement with unstimulated whole salivary flow being less than 1.5 millimeters, parotid sialography showing presence of diffuse sialectasias, and salivary scintigraphy showing delayed uptake with reduced concentration. The autoantibodies are also another positive test for Sjogren's. These include antibodies to Rho and La, SSA and SSB antigens, or both. The aqueous deficient dry eye can also be a non-Sjogren variety. The non-Sjogren variety can be due to a lacrimal gland failure or lacrimal deficiency, lacrimal gland obstruction in cicatrizing conditions, reflex block, which can be due to reflex-induced lacrimal secretion and reduced blink reflex and increased evaporative losses. And there can be a reflex sensory block, which is common in diabetics, and it is also in neurotrophic keratitis caused by herpes simplex virus. Some systemic medications can also lead to such a condition. Evaporative dry eye results from the ocular surface losing water in the presence of a normal lacrimal gland function. It can be extrinsic or intrinsic. Extrinsic causes of evaporative dry eye include ocular surface disease such as allergic conjunctivitis, vitamin A deficiency, contact lens wear, preservatives used in common ophthalmic medications. Many components of dry eye formulations can induce toxic responses from this ocular surface. The most common culprit is benzalkonium chloride. This causes surface epithelial damage, punctate keratitis, and interferes with surface wettability. Another common group is glaucoma patients who have been treated for years on anti-glaucoma medications. Contact lenses are also extremely liable for causing dry eyes. It has been found in a report that contact lens wearers are 12 times more likely than emmetropes to report dry eye symptoms, and 5 times more likely than spectacle wearers to have dry eyes. So in a nutshell, the aggravating factors include hot climate, exposure to chemicals, dust, smoke, prolonged use of computers or reading. The features in addition one should look for in a patient of dry eye are features of blepharitis, and meibomitis, reduced tear film height, mucus debris, discharge, keratinization, superficial punctate keratitis, epithelial defects, plaques, and filaments. So it's quite common to see, and yet very commonly overlooked in the clinic, are the obstructed meibomian gland orifices and some expression of a milky fluid when one gently presses the lid margin. There may be some scales which are there in between the eyelashes. These could be some signs of blepharitis, and there might be some notching of the posterior lid margin which suggests a irregular tear film. So one needs to do a careful examination of the ocular adnexa when evaluating a dry eye patient. So central to this is the blepharitis and the meibomitis, and very commonly one should also look for signs of obstruction of the meibomian gland orifices with some whitish or foamy material. So when the patient has a chronic dry eye, there may be sequelae such as areas of corneal thinning, there may be perforation, they may be secondarily infected. Treatment of these conditions are crucial and need to be treated as per the cause. So there are a battery of diagnostic tests that are available in dry eye. These could be Schirmer's, tear film breakup time, ocular surface staining, questionnaires, impression cytology, measurement of tear film meniscus, esthesiometry, ocular surface scraping, osmolarity, and meibography. So what is the hallmark of dry eye disease? Okay. So the hallmark is raised osmolarity of tears. There are several common tests which are performed in dry eye disease. So the most common and the most familiar test of all is the Schirmer's. It's a common office procedure. There is a wide variability of under different testing conditions. The degree of wetting of the Schirmer strips may be from 8 to 33 millimeters. And in severe dry eyes, values below 5 millimeters are of significance. The other common test that is used as an office procedure is the tear film breakup time. We don't exactly know the mechanism of that. There is probably a break in the mucus layer which allows the aqueous to reach the surface, causing dry spots which, as shown in the video below, appear as prominent areas where the tear film starts breaking up into, and that is, as you can see here, is a dry spot that is slowly appearing where the fluorescein starts breaking up. So again, there is a wide variability of results. Less than 10 seconds suggests tear film instability, and less than 5 seconds suggests definite dry eyes. There are several patterns of ocular surface staining that is also noticed in dry eyes. 6 areas of the conjunctiva and 5 areas of the cornea are traditionally graded as per the NEI industry workshop guidelines. The several grading schemes in addition to the NEI are the Van Gesterveld and the Oxford grading system. They are scored from 0 to 3 or 0 to 5 as per the Oxford scheme, with a maximum score of 9, 15 for the cornea and 18 for the conjunctiva. Different ocular stains are also available to look at the degree of ocular surface damage. They include fluorescein stains, rose bengal, and lissamine green. Fluorescein stain surfaces where cell-to-cell tight junctions are absent. Rose bengal stains dead devitalized cells and causes burning and stinging. Lissamine green also stains dead devitalized cells but without staining or affecting the viability of cells. So the dry eye or the dysfunctional tear syndrome panel have proposed different staining patterns of fluorescein in patients of dry eyes or those who have attendant dysfunctional tear syndrome, which includes dry eye as part of the pathology. So in severe keratoconjunctivitis sicca, there is a diffuse staining of the ocular surface. In moderate conjunctivitis, keratoconjunctivitis sicca, there is an interpalpebral staining. Whereas in blepharitis or exposure, there is a typical inferior corneal staining. Medication toxicity is typically towards the puncta. Contact lens causes a 6 and 9 o'clock staining, and superior limbic keratoconjunctivitis or foreign body causes a superior corneal staining. Similarly, these are the patterns of rose Bengal staining, where from moderate or severe keratoconjunctivitis sicca may have diffuse patterns of staining as opposed to SLKC, which is superior limbic keratoconjunctivitis, and mucus fishing syndrome or chemical injury, where the surface is stained inferiorly and superiorly respectively. In addition, it is useful to administer a ocular surface disease index questionnaire. So it's important to ask the patient about symptoms of dry eye, which are that whether the eyes are sensitive to light, whether they feel gritty, painful, sore, blurring of vision or poor vision, and how often the patient experiences these symptoms, whether it is sometimes or whether it is all the time. And then the subtotal of all is given into a score, which is one part of this questionnaire. The other parts include that whether there are problems with some tasks such as reading, driving, working with a computer or bank machine, poor vision, and whether the eyes are uncomfortable in any particular situation such as windy conditions, low humidity, air conditioned areas. One needs to add up all the scores A, B and C and then obtain a total score, and then also look into the total number of questions that are answered by the subject. So then there is a standard scale where the number of questions and the sum total of all the scores are graded, and then it is calculated as the sum of scores into 25 divided by the number of questions answered, which gives the total score of the ocular surface disease index. Another useful tool is the Visanti OCT, which provides accurate measurements of the tear height in a non-invasive fashion with acceptable sensitivity and specificity, and it is a reproducible test. Ocular surface scraping can show keratinized epithelial cells. Note the keratin granules that could be seen in dry eyes, superior limbic keratoconjunctivitis, or exposure keratopathy. Eosinophils can be seen in patients with vernal keratoconjunctivitis, atopic keratoconjunctivitis, or other allergic processes. Osmolarity is the hallmark of dry eye, and preferably the tests for osmolarity needs to be done before any other tests are administered, so that one can get the tear film which is not affected by installation of different drops or stains into the eye. A 50 microliter tear sample can be easily collected with minimal disturbance of the tear film. Aesthesiometry is again helpful to know the state of the corneal sensation, assess a poor blink rate, and the degree of sensitivity of the cornea. This can be done with a Cocktail-Bonnet aesthesiometer or a Belmont aesthesiometer. Corneal topography is also another useful adjunct where dropouts or decreased quality of the Myers from the tear film can note tear film irregularities. The Placido image helps to identify tear film quality. In addition, the meibomian glands are also very well displayed. and any dilatation, dropout or distortion of the meibomian glands can tell us about the state of the health of the meibomian glands. The risk factors for dry eyes include older age, female gender, postmenopausal estrogen therapy, medications like antihistamines, connective tissue disorders, refractive surgery, radiation therapy, etc. It's quite an extensive list, but these are the conditions which are the most common and which are the most consistent risk factors for dry eye disease. Dry eye disease severity can also be graded from mild to severe based on the discomfort that the patient faces, visual symptoms, conjunctival injection, staining, corneal and tear signs, lid, meibomian gland condition, the T-butt, which is the tear film breakup time, Schirmer's course. So, when there is an unstable tear film, it's important to look for the tear meniscus height and the result of the Schirmer's test. And then categorize that whether you are dealing with a aqueous tear deficiency or a aqueous normal condition. So if there is a level 1 aqueous tear deficiency, one needs to use lubricating drops, hydrate it, or use osmoprotectives such as omega-3 or 6 essential fatty acids, or use punctal plugs. Or if it is a more severe variant of aqueous tear deficiency, then use anti-inflammatory agents or a protease and some adjuvant drugs such as steroids, cyclosporin, tetracycline, azathioprines, or serum albumins. In addition, punctal occlusion and PROS are also additional tools in the armamentarium of the ophthalmologist in treatment of severe dry eyes. In aqueous normal conditions, one needs to look into meibomian gland disease, which needs to be treated with artificial tears, expression of the meibomian gland secretions by warm compresses and lid massage, and in case of a blepharitis or meibomitis, one needs to treat with tetracyclines or azithromycin. When there is an altered distribution due to any other conditions such as conjunctival callosis, pinguicula, pterygium, lagophthalmos, or exposure, then one needs to treat as per the etiology. So, which lubricants are best for alleviating symptoms of dry eye? So, preferences, practice, and prescribing patterns differ amongst ophthalmologists. There is an interesting Cochrane study on this, and the researchers found that over the counter artificial tear drops for dry eyes may be the safe and effective means of first-line treatment of dry eyes. However, the literature indicates that majority of artificial tears have similar efficacy. Thus, artificial tears can lubricate the ocular surface and reduce the osmolarity of the tear film, protect the ocular surface from desiccation. However, there is no distinct advantage in ocular surface protection that has been found with any particular brand. The decision is based on preference and the preservative. The common preservative that is there in artificial tears is benzalkonium chloride. However, this is something which causes a lot of ocular surface toxicity. It disrupts the epithelial tight junctions, accelerates the desquamation of epithelial cells, promotes apoptosis in low concentration, and causes necrosis of surface epithelial cells in high concentration. Its effect is worse in aqueous deficient dry eye, especially in the presence of punctal plugs, as the ocular osmolarity is increased. Milder alternatives include purite, sodium perborate, or unit dose which are preservative free. Autologous serum is another alternative which contains mediators that support the proliferation, differentiation and maturation of the normal ocular surface epithelium. This is attributed to epidermal growth factor, vitamin A, lysozyme, fibronectin and TGF-beta. So there is another Cochrane study where the investigators reported inconsistency in possible benefits of autologous serum for improving the signs and symptoms of dry eye. While there may be some short-term benefits of using autologous serum, however, there are no evidence of a beneficial effect of autologous serum over artificial tears after 2 weeks of therapy. Punctal occlusion is another way of preserving the tears in a patient of dry eyes. So there are several mechanisms by which one can do that. One can do a dissolvable intracanalicular plugs which are placed into the canaliculi on a trial basis, or can perform a permanent punctal occlusion with a disposable thermocautery or with a radiofrequency needle. The techniques include surgical, thermal or tamponade. So thermal punctal occlusion by cautery, diathermy or laser destroys or shrinks the canalicular walls. Tamponading methods are popular because no surgery is involved and it is commonly performed as an outpatient procedure. Observable inserts such as HPMC, collagen or collagen implants can also be used. HPMC stays for 18 hours, whereas collagen implants can last for as long as 2 weeks. It reduces the outflow by 60 to 80%. Non-observable materials include silicone, hydroxyethyl methylacrylate, and Teflon. They are usually placed under topical anesthesia and the punctum are also dilated. There are two general styles of punctal plugs. One is the arrow or the umbrella variety, where there is a vertical portion, a collar or ring on the top of the plug with a narrow neck, and it facilitates retrograde plug removal and decreases the risk of plug migration. The other is the fluted funnel or golf tee, where there is a horizontal portion which is removed in an antegrade fashion. So this is the arrow variety, where you can see the tip, there is a collar and there is a ring which sits on the top of the punctal or the lacrimal punctum. They come as tele-packs and they need to be introduced as an office procedure under topical anesthesia after dilatation of the punctum. However, punctal plugs can have a lot of complications. These include irritation of the conjunctiva, cornea, pruritus and discomfort, rupture of the punctal ring, suppurative canaliculitis, canalicular stenosis, pyogenic granuloma, and dactylocystitis. The plugs may also be extruded or they may promote a biofilm formation. Punctal occlusion for dry eyes. We don't really have a lot of literature and there is very limited data which has found that It may be of limited benefit in dry eye disease. Anti-inflammatory therapy as an adjunct for dry eye disease includes cyclosporin, corticosteroids, tetracycline, azithromycin, and essential fatty acids. Cyclosporin prevents T cell activation, prevents this ocular surface inflammation and apoptosis. Topical cyclosporin has also been found to increase the density of mucous goblet cells in the conjunctiva. It's administered in twice daily dosing. Corticosteroids are potent immunosuppressors which control the ocular surface inflammation. However, one should use low potency steroids such as fluorometholone, Lodex, Lotipred to avoid raised IOP. Corticosteroids can be combined with anti-inflammatory agents like cyclosporin. Tetracyclines have an anti-inflammatory effect and it stabilizes the tear film, decreases the meibomian gland dysfunction and rosacea, and it is useful to treat recurrent corneal erosions. Azithromycin helps to have an antibacterial effect on common agents of anterior blepharitis, and that includes Staphylococcus. A number of studies have shown improvement in signs and symptoms of meibomian gland dysfunction with the use of azithromycin. Essential fatty acids have also been found to improve the symptoms and signs of dry eye disease. Some secretagogues such as pilocarpine also stimulates the exocrine glands and improves corneal staining. Less toxic agents include cevimeline, which are used as secretagogues in dysfunctional tear syndrome or dry eye disease. Contact lenses such as PROS is also a useful alternative in patients with severe dry eye. These are basically fluid-filled reservoirs which hydrate the cornea and shield it from blink trauma, noxious environmental stimuli, and inflammatory mediators. So when the ocular surface is damaged with a distorted cornea, this scleral PROS device actually acts as a saline reservoir on which sits on the cornea and promotes the hydration and prevents noxious environmental stimuli from irritating the ocular surface. So this is a patient of, this is a patient of Stevens-Johnson syndrome who has a lot of ocular surface discomfort. So we can see the PROS, which is a very large lens that sits onto the anterior surface of the cornea and the adjacent part of the sclera, and it keeps a tear film reservoir underneath and helps in alleviating the symptoms of dry eye. So in conclusion, the ocular surface is important for the health of the eye as well as the vision. The paradigm shifts are those of the are a mucin aqueous glycocalyx gel. The elevated tear film osmolarity is central mechanism for ocular surface damage, and dry eye can be categorized into aqueous deficient or evaporative dry eye. So when there is an unstable tear film, one needs to categorize it as whether it is a aqueous deficient dry eye or evaporative dry eye, and then one needs to treat as per the etiology and the severity of this condition. I would like to acknowledge colleagues who have helped with the materials used in this topic for discussion today. Thank you, and we can take questions now.
So Dr. Roy, you can stop sharing your screen.
Okay.
And it looks like we have one question in, if you want to open that up.
Okay. All right. Thank you, Lawrence. So tacrolimus is mostly a immunomodulator. It has been used for dry eye. We use cyclosporin. I personally use tacrolimus mostly to treat vernal keratoconjunctivitis. But in dry eye, I have very limited experience of tacrolimus.
So Dr. Roy, maybe you can stay on for a few more minutes and we'll see if more questions come in.
Okay. Azathioprine or tetracycline is used mostly as ointments, and yes, they are available commercially. What's PF lubricants? I'm not sure I understand what the question is. Could you please elaborate? This is a very interesting question. What is the role of surgery in the management of dry eyes? Okay, so one needs to stabilize the ocular surface before one undertakes any surgery, such as cataract surgery. It is very common to have patients who have dry eyes as well as a visually significant cataract. So it's important to find out the cause of the dry eye, treat the cause, give supportive management, allow the ocular surface to stabilize, and then go for surgery. Preservative-free lubricants, yes, those are useful when one used to chronically use these medications and the patient is sensitive to preservatives like benzalkonium chloride. Chloramphenicol is useful if there is an attendant meibomitis or blepharitis. And chloramphenicol is also used as a mild bacteriostatic in the setting of a poor ocular surface with a ocular surface disease like Stevens-Johnson's, or when there is a graft or there is a drug toxicity and one needs to stop all the antibiotics. How does the ocular surface disease index affect the management? It is another investigative tool that is used to quantify the degree of discomfort that the patient has due to dry eye. Punctal occlusion can be done, again, these are temporary methods. The permanent punctal occlusion can be done where we want to completely block the punctal orifices. The temporary punctal plugs are used for a period of couple of days to 2 to 3 weeks. So when do we select? Okay, what is the treatment plan for dry eye in young children? Very rare. But then again, supportive treatment and treat the cause. Certain type of sunglasses, no, not aware of those. Which cases do we select drops or gels? Wherever you want the eye to be protected for a longer period of time, but the patient is not able to frequently instill the drop, then use a gel which stays on the ocular surface for a longer period of time. Sjogren's, again, treat the cause. and also gives supportive treatment with topical lubricants, and also gives immunomodulators such as steroids and cyclosporin. Gels are needed and sometimes also look for exposure and then treat it accordingly if it is there. But most important is to treat the cause or control the autoimmunity. No, dry eye is not implicated in the pathogenesis of pterygium. Pterygium is mostly due to exposure to ultraviolet rays in sunny tropical climates. Paradoxical tearing is a neuro-related condition. I think something like crocodile tears. Better management of dry eye problems in people using computers. Computer vision syndrome is a new entity due to different working conditions where people need to use a lot of time before uh, computer monitors. So traditionally or classically, they tend to blink less frequently. So it would be advisable for them to actually take breaks frequently, if possible within an hour. Avoid sitting directly in front of a draft of air from the air conditioners, because air conditioners tend to be very dry and tend to dry out the ocular surface very fast, and use any artificial tears whenever there are symptoms of discomfort. Cause effect relationship between dry eyes and pterygium, none that I am aware of.
So we have about 15 minutes left if more people want to submit questions.
Dry eye is very common in the setting of refractive surgery, and patients often tend to have episodes of discomfort, dryness, irritation, and burning almost more than 3 to 6 months after the surgery. Treatment options for computer vision syndrome I discussed: take breaks, blink often, blink consciously, use artificial tears. Esthesiometry is a test which is done to test for the corneal sensation. The commonest way of doing esthesiometry is allowing the patient to look straight ahead and then stand by the side of the patient and then use a wisp of cotton to touch different areas of the cornea. It is done first for one eye and then for the other, and see how rapidly the eyes blink. However, this can be done quantitatively using the different aesthesiometers. The most damaging effect of dry eye is thinning, perforation, and secondary infection if it occurs in a patient who has had a poor ocular surface due to dry eye, can be very difficult to manage because these patients usually do not do well even if a corneal transplant is done for a perforation or a therapeutic transplant is done for a non-resolving corneal infection. Seventh nerve palsy causes lagophthalmos, so tarsorrhaphy may be needed. In a simple way, one can also tape the lids together and use a lot of lubricants, of course. Treatment options for computer vision syndrome, I have answered it twice. It's using artificial tears and blinking and taking breaks frequently. And of course, avoid sitting directly under a air conditioner draft of air basically. So the conjunctiva has a lateral and medial area, upper lateral and upper medial zone, and the lower lateral and lower medial zone. The cornea is divided into 5 zones: central, and then superior, inferior, medial, and lateral. How long should you use cyclosporins? You use until the surface is stable and the surface doesn't show a lot of staining patterns with either fluorescein or with rose bengal or lissamine green. The first results usually come after 2 to 3 months. Any drug which contains preservatives and used for a long time. The most common clinical scenario is the anti-glaucoma medications. They typically cause dry eyes. Systemic drugs like Accutane can also cause dry eyes. Topical cyclosporin is available as 0.05 or 0.01% concentration. So computer vision syndrome, again, take breaks, blink consciously, use artificial tears, and avoid dry environment. Yeah, if the climate is very dry and the patient is symptomatic, then maybe you can use artificial tears. Okay, I think this is the favorite question of the evening, computer vision syndrome. So, okay, so same, use a lot of artificial tears, blink frequently. How long you use lubricants? Well, as long as it's necessary. Yeah, somebody answered the computer vision syndrome also. Antibiotics, there is no role of antibiotics in dry eye, and we use lubricants as long as the patient is stable. Antibiotics are used in the setting of blepharitis or pneumonitis to treat the attendant ocular adnexal pathology. Best lubricants, There is a Cochrane review which says that no lubricant is superior to the other, all have similar efficacy. Vitamin drops, again, these are anecdotal evidence, not really definite that whether they have any beneficial effects.
So we have about 10 minutes left if people want to keep submitting questions.
A role of eyeglasses in management of computer vision syndrome, none that I am aware of. If patient has dry eyes and needs to have a cataract surgery done, then one needs to manage the dry eye, look at the extent of damage to the ocular surface, treat, stabilize the ocular surface, and then go ahead for cataract surgery. So this can take about a month or 6 weeks or 3 months before the surface is stable and one can go ahead and plan for a cataract. Maybe you should treat the dry eye and of course, also treat the cause due to which the patient is experiencing dry eye. Change in post-operative dry eyes after advent of echo, I'm not aware of that. Elderly people can have dry eyes due to other causes too, in addition to the surgical incision. So a minimal surgical incision can have a very limited effect on the ocular surface, and it also disturbs the ocular surface to the minimum.
So we have about 5 minutes left for any last questions for Dr. Roy.
I'm not sure I understand this last question. Would you mean hydration or Not aware of the effect of drinking water. Quick's method of diagnosis. Not really sure. Omega-3 fatty acids are also being promoted to have some adjunctive role in the management of dry eyes. Well, there is no definitive evidence, no harm in having them also. They have other nutritional benefits, but not really sure about how it may help a patient of dry eyes. There is some evidence though that they may have a beneficial effect in patients with dry eyes. Possible to prevent, well, if you can prevent the cause, then definitely you can prevent the effect also. Dietary preferences, nothing in particular. But then there are so many vitamins, multivitamins, omega-3 fatty acids, essential fatty acids that are marketed and promoted. So there are several natural sources of that. One can explore those options. Use as long as possible, or as long as the patient can afford. There is no definitive evidence of the beneficial effect or the harmful effect of dietary nutrients. So no particular dietary preferences, and again the omega-3 fatty acids can be used SOS.